Hello everyone, and welcome to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein. Now, it's been a couple weeks since we've been able to update you, and so today we're giving the entire program to Dr. David Reznik for his clinical update. Dr. Reznik?
Thank you, Gary, and it's good to be back giving a clinical update on what has been going on with the COVID-19 pandemic, how it's infecting or affecting our practices, and what we can do to bring our patients back, I think is one of the best things that we can start off talking about. So what are our most pressing concerns? What is your most pressing concern when it comes to this pandemic? Do we have enough adequate PPE? How are we going to provide the safest dental visit for all of our patients and staff alike? How do we get our patients back? Some are maybe hesitant about coming back into the dental office. You might have seen some recent publications by some of our leading infectious disease docs saying that they might not go to the medical office at this point, or unless they were really due for a visit, or they might not go. And we actually have some that will go. So we need to talk about focusing on bringing our patients back so we can do that service. Remember, you can't be healthy without oral health. So we really need to do our part of primary care, which is maintaining health, eliminating pain and infection, restoring function, and of course, making people as beautiful as we can. How can we safely perform aerosol generating procedures? Are we going to have to use new technologies? And what technologies will they be? And how are those technologies working in the real world? What are our best practices on reassuring our staff and patients that everything is going to be fine, that it's going to be okay? I love the blank question because each of us has our own concerns. Is it paying staff? Is it, will I be able to do the kinds of procedures I've used to be able to doing? Am I a special needs dentist and have special circumstances? What happens if I'm doing a certain procedure and I need to take the handpiece out, say an extraction that goes into a different direction? There are a lot of hurdles that we faced. This has been one of the most challenging times in dentistry, and as you all are aware, I started my practice right before HIV was prevalent in my community in Atlanta. Didn't have a whole lot of training, faced that one head on, and we realized that we could manage that patient population, and we adjusted. And due to all of the adjustments we made in infection control practices in the past based on HIV, we're really just taking it one step further now with this new COVID pandemic. So dentistry has always been at the front. I don't laugh at my staff when they doff and don, and we're actually going to talk about that later on. But I do say when I saw my medical colleagues put a doffing and donning for the first time, it was entertaining, and my only regret was that I didn't take pictures to share with you today. One of the biggest things that we can do is communicate. We have to communicate with each other. We have to learn. We have to communicate with our staff to make sure that everyone's comfortable, that we have the equipment, that we're following those incredible protocols that have been put out by the American Dental Association, the guidelines by the CDC and ADHA, and of course that one document by DentaQuest and OSAP that puts it all into a document. Are we comfortable following these procedures? Are people actually listening to us? Have we practiced wearing N95s or KN95s and realize that breathing could be difficult? How do we get accustomed? But one of the key things that we need to do is communicate with our patients. We need to let them know that things are going to be different, but we're taking every possible precaution to ensure that they have a safe visit. That we will ask pre-questions before they come, that we might ask them to stay in their car, and that we will text them when it's time to come into the office, that we will be screening for temperature, that you might get used to only seeing us basically from the eyes up, that we're going to be fully covered and protected back in the clinic area. I've been doing this for a while, and I can honestly say, even with all of the garb on, we can still establish and maintain our remarkable relationships with the patients we've had so many years. But I really think we have to be more aggressive. I think there have been some social media posts out there that are sort of negative and try to lead people into fear. And I think if we have positive stories to reinforce our communities, our cities, our states, our rural communities, those out west, even places that are having spikes in the virus at this point, if we can communicate the importance that we're taking all of the precautions that we can to ensure a safe visit, our patients will come back. They come to us because they trust us. We've done a pretty good job of connecting the oral cavities to systemic disease, and people know that to stay healthy, you have to have oral health. So the ADA, the American Dental Association, has launched a patient communication resource center. And it's for members, but it's customizable communication tools for practices to use with patients during the time when many dentists are reopening or are open and they're seeing a reduction in the number of patients, or maybe we're having a difficult time getting some patients back in. It's a 10-page guideline that they put to work. It's based on their return to work interim guidelines, and it's based on what the ADA Advisory Task Force on Dental Practice Recovery came up with. So we want to support our dentists, we want to support the dental teams in communicating about changes that they're going to experience when they come in for non-emergent care. So again, if you keep people informed, you keep reaching out to people, and maybe sending texts or whatever you want to do to communicate with your patients, there's different ways of communication to let them know that you are doing above and beyond and it's safe to come back. That will definitely be helpful. So when you look at the American Dental Association's Health Policy Institute, they ask some certain questions. And what I've done is look at some of the core questions and thought maybe we'd take a few minutes to look at them together. So when the question is asked, what is the current status of your dental practice? If you look at March 23rd, which I believe was the beginning of the series that we're in the midst of it with Henry Schein and OSAP, you can see that 76% of the offices were closed and only seeing emergencies. About 19% were closed and not seeing any patients. And then we saw a little bit of an increase in those that were willing to treat emergencies. But now looking at the week of June 15th, we see almost a third of our patients open with business, of our clinics, our offices, open with business as usual. We have the majority, about 63%, that are open but with lower patient volume, which is why I'm stressing that communication component. We still have a small degree that are closed but seeing emergency patients only, and we have a very small degree that are closed and not seeing any patients. So I think it's important to point out that as of the week of June 15th, which is some time ago now, 97% of dental practices in the United States were open, and 1/3 were reported that business was as usual. So it could be low prevalence areas, it could be taking special precautions, but we are making progress and things are looking up. And I'd like to point out the positive. Is your practice paying staff? Well, that's really a positive for your staff members as they work for a reason. I mean, they work because they love what they're doing, and they also work because they love their jobs and they need their money. So at the week of March 23rd, you can see that 27% were being paid fully. But then on April 6th and April 20th, you saw a marked decrease. People started to realize that the practices weren't going to be the same, and so there were some concerns. Partially paying staff, you can see that was around 45%, March 23rd, April 6th, and April 20th. And then not paying any staff reached its max on April 20th. Now, if you look at June 15th, 85% of practices are fully paying their staff, and that is a remarkable recovery. So again, I want you to look at it as not everybody is at this place, I understand it, but a lot of people are recovering. We're moving in the right direction. It truly is about putting the right program and practices in place and making sure you have all of the equipment that you need. So how many days worth of the following PPE does your practice have? So let's go back and look maybe at the week of May 18th, where there were 0 days of N95s or KN95s at 15%. That is pretty significant. Now let's go look at that number today, and it's very, very small. If you look at the number of gowns, I would look at this through the entire spectrum here because it's been a problem. 25.8% said that they had 0 days of gowns on May 4th, but still, as the week of June 15th, almost 9% of the offices are saying they're having a hard time with gowns. And that is becoming a bit of a universal problem and something that we're going to need to keep in mind. One of the ways that we are trying to take advantage of the number of disposable gowns that we have is if we are doing non-aerosol generating procedures and it's just exams, or if we're adjusting a denture or we're doing impressions, if there is no aerosol produced, we're wearing coats. We can change out our lab coats and we have a service that manages them. Anything that has the potential to produce an aerosol, we are then using with our disposable gowns. And as I've said, there have been some questions about how you put on masks and how you put on gowns. And actually, we're going to show some videos later on in today's webinar on how to do that correctly, because that is so very important. If you look at face shields, we seem to have a pretty good supply of face shields and surgical masks now. N95s, we're doing better, and K95s, we're doing better. Almost 50 or 49% of offices have more than 2 weeks worth of N95s or KN95s, and that's what is necessary in order to provide aerosol generating procedures. Surgical masks, the numbers are doing great. Face shields, the numbers are doing great, and that was a problem very early on in the epidemic. And gowns, so we have enough for 2 weeks for about 47%. So I think the area, if I were to focus on an area of concern, it probably would be with gowns. But if you have a good relationship with your supplier, a good relationship with the companies you've worked with, you've already probably worked that out. And remember, there's some other really remarkably good toys or tools out there. One of the things that I'm worried about with PPE is you can actually measure the amount that you have and plan out. There is a tool that is available through the ADA and some of the things I've covered at this point, which will allow you to actually look at your PPE, your utilization rate, and make sure that you're keeping enough of the product online. So what are some of the key takeaways from the data that we heard in June? Our dental economy is rebounding. Great news. As the week of June 15th, 97% of the offices in the United States were open, and patient volume had rebounded to about 65%, which is really excellent. And 27 states have been open for elective care for at least 7 weeks. The recovery is further along and does not show signs of flattening. So when you're open, you're doing the procedures, word of mouth, it's safe, it was a remarkable environment, they did this, they did that, they did the other. Things I've never seen in a dental office before. Patients are staying, volume is increasing. The stockpile of personal protective equipment in dental offices continues to increase. Past 2 weeks saw a significant improvement in the PPE availability. Again, I'm just asking you to keep an eye out on your gowns and use them wisely. Updated modeling, and that's something that comes from the American Dental Association's Health Policy Institute, which takes into consideration the most recent data, indicates that the United States dental spending could shrink over a third in 2020 and 0 to 20% in 21. So we sort of have to make it through, get our equipment in, communicate with our patients, do best practices, and regain that trust our community has always had in us. So taken together, the data continues to indicate a robust recovery in the dental economy, and it doesn't show a sign of plateauing at this point. So good news. Not so good news is that we all, if you turn on your news, you turn on your computer, you turn on the radio, you know that we still have an ongoing pandemic in the United States. 34 states are considered hotspots in the United States. And I show you a graph here, which is hopefully a lot nicer than the graph I showed a few weeks ago, that 34 states account for 70.1% of the total U.S. population, and these 34 states are hotspots. So I'm sure you've all been aware of stories that you've heard out of Arizona and California and Texas and Florida. I live in Georgia. I can tell you that our hospital cases are going up. I work with an organization based in Tampa, Florida. Their ICU beds are at maxed out. I'm just giving you this information to say that we haven't gotten out of phase one. We do need to follow all of those protocols that were put in place. And how do we decide what these COVID hotspots are? Cases have increased by 5% in more than 14 days, or positivity rate on a 7-day rolling average is 10% or greater. So you can see this is an ongoing pandemic, and this is data that is presented before the last holiday weekend. And if you remember, after the last holiday weekend, we had a pretty significant spike in cases. At least 20 states set a record high in the last 7 days for the number of cases. Florida, Texas, California, Arizona, Georgia, my home state, and North Carolina presently have the most infections. Cases during the most recent 14 days have seen an increase of almost 90%, which is remarkable. The good news we have at this point is that during the same period of time, deaths have been down almost 20%. Now, that's great news, but please be aware that sometimes this information does lag. That just because someone tests positive, then we have the whether or not they go into the hospital. So how many of those patients are hospitalized? And then regretfully, a few weeks after that, up to a month later, how many have passed. So we're about a month away from finding out what the consequences are of these new increases. But since it's impacting younger people, the hope is that the death rate will remain low. However, just because approximately 1% in the United States may die from this, that one is a significant number of people. We're over 130,000 deaths at this point. And two, there are long-term consequences of getting this infection for many other adults and children. So let's just not think it's the flu and we got past the flu. We need to take all of those precautions, that physical distancing in a dental setting, which is hard, wearing a mask in the clinic. The hospital says if you are in the hospital, you will have a mask on unless you're in a private office like I am today. The New York Times had an update, which is, again, not the best news. What they did was they looked at every state as if it was a country. And there is no country in the world where confirmed coronavirus cases are growing as rapidly as they are in Arizona, Florida, my old home state, or South Carolina. The Sun Belt has become the global virus capital, and that is somewhat horrifying. The number 4 country that shows up on the list is Bahrain. So it ranks countries with the most confirmed new cases over the past week, adjusted for population size, and treats each U.S. state, as I mentioned earlier, as if it was a country. The only countries with outbreaks as severe as those in the Sun Belt are Bahrain, as I mentioned, Oman, and Qatar, so Middle Eastern countries. Israel, all of a sudden, has a huge problem, and they didn't have a problem. They are literally talking about this being phase 2. In Israel, we're over 1,000 cases per day, and it literally started breaking out in schools. Sweden, which allowed the virus to circulate unchecked, has Europe's worst outbreak, and their economy hasn't benefited. So again, take the steps necessary to keep you and your family healthy and safe. Take the steps necessary to keep your team safe and productive, and yourself safe and productive, and your family safe and productive. It really isn't much to wear a mask. It's not any kind of statement. It's a statement that I care about you and that I don't want to give you whatever it is I might have. Now, why are we seeing all these new infections? Does testing have a part of it? There is no question. The more tests you do, the more cases we're going to find. That is not rocket science. But why are we seeing so many cases? Why are we sort of like what happened in Italy? Why aren't we one of those countries that maybe had a few hundred, few thousand cases and then it sort of went away? Well, a Duke professor and a colleague of his, and the Duke professor, Dr. Montefiore, who is a professor of surgery and the director of Laboratory for AIDS Vaccine Research and Development at Duke, was actually looking at this along with one of his colleagues, Dr. Betty Korber, who is an expert at analyzing sequences at our Los Alamos National Laboratory. And they've worked together looking at HIV for some time. They both noticed this increase in these spike proteins, those little spokes that we see on the outside of the cell whenever you get a COVID picture. So they're looking at the genetic sequence of the virus, and very early on, they found that there was a change in these spike proteins. And that's how you attach to the cell, is with these spike proteins. Dr. Korber noticed this mutation that we call D614G in the spike proteins very early on with a very small number of cases. There were only 6 cases in early March. So it became a mutation of interest for her. As she started looking at other cases, she noticed that it was spreading and that it was more fit. And within weeks, it was found in more and more people. And as they came into the database, more and more of these sequences were coming into the database. By April, they knew it was the dominant strain of the virus globally. And how did they know that? Well, the mutated virus, what do we know about this mutated virus? It's not causing a more serious illness. And I think that's always our concern. When we look at mutated viruses in HIV, we've always been concerned that we have drug mutations, that the virus has learned how to outsmart the medications. And we've been dealing with that for years in HIV until we came up with combination therapy. But right now, this highly contagious, more fit virus, which has become dominant, just spreads easier because it is wants to survive and transmit. That's what it does. So the mutation does not impact any kind of research into vaccines or the therapeutics that have been going on. All of those vaccine trials are moving forward. I'm sure you've heard. But Dr. Montefiore really doesn't believe the mutation is the reason why we're seeing more cases and more hospitalizations. I have to say we have more patients in our hospital now than since May. We have more patients in our ICU now than we have in some time. So there are other things that are going on, underlying conditions, social determinants of health, who is being impacted by this disease, do they have access to health care? But our hospitals are once again filling up. Again, we can prevent this. We can do things to prevent this. What about our pandemic? You know, we've always heard all this stuff about, well, the U.S. is doing poorly compared to the European Union. Okay, the European Union is across an ocean and all that stuff's going on, but what about how we're doing compared to our friends, our neighbors, our relatives in Canada? We share an enormous border with Canada, 5,525 miles. We share a common language for the most part, and trade. It's our greatest ally, has been a great ally for years. We're in the same continent. Of course, there are a lot more people in the U.S., but Canada has 107,000 cases with 8,700 deceased. The United States has greater than 3 million cases and 130,000 deceased. So we can see that there is a difference. So we have to do what we're doing better. Something else that I think dental healthcare professionals have been dealing with since the beginning, we've always treated this virus as if it was airborne. We produce aerosols with most of the procedures that we do. So this is not new news to us, but it's new news to the public. Almost 240 experts came out with one big claim: the coronavirus is airborne. It's finding new victims worldwide in bars and restaurants, offices, markets, and casinos, giving rise to frightening clusters of infections that increasingly confirm what many scientists and physicians and colleagues of mine have been saying for months: the virus lingers indoors, infecting those nearby. So if airborne transmission is a significant factor in the pandemic, especially in crowded spaces with poor ventilations, the consequences for containment will be serious. And I think we're seeing that. As healthcare workers, we wear N95 masks that fill out the smallest respiratory droplets when we have patients in the chair. But what of our ventilation systems in our offices? What can we do to improve our HVAC systems? And as I've mentioned in past webinars, there are some instrumentation you can buy by calling your local reps that will help with air purification and HEPA filters. I also strongly recommend that you get in touch with an HVAC person. Even if you do buy one of these products, they're best with installing and no airflow and things of that form. Ultraviolet lights also might be helpful, UVC to kill viral particles floating in tiny droplets. So the importance of all of the new technologies that Dr. Severance and others on Henry Schein's webinars have been talking about for some time are truly important. What can we afford? What can we use? But really it comes right down to what can we do to create a safe environment for all staff and patients so everyone feels comfortable coming back and our practices are back to full strength. So even in the latest update on coronavirus, which released on June 29th by the WHO, they basically said airborne transmission of the virus is only possible after medical or dental procedures that produce aerosols or droplets smaller than 5 microns. Instead, the WHO really kept pressing on the fact that hand washing was the predominant way of preventing transmission. Now, as a dental healthcare worker, as a dentist, I'm never going to downplay the importance of hand washing. As someone who has been talking to you for months at this point, please make sure you wipe down the hard surfaces in your waiting rooms and you eliminate unnecessary paper, that you get those doorknobs, that you have tissues available with the receptacle, and that you have signs up talking about the importance of respiratory hygiene. And really, even if you want to, send out messaging to your patients on what are coming up, on what to expect when they come into the office. So our U.S. Centers for Disease Control now says services really don't play that big a role. However, if they play any role and we can prevent it, just wipe down those services. I know we're doing it in the dental operatories. One area that we have not done it in the past has been in our waiting rooms, but we should have been doing it now for the last several months. Where are we with vaccine progress? You're hearing a lot of news. Some of it's very exciting, that people are making this remarkable progress and that we have so many different agents in different phases that are going through this process. It's actually remarkable to me. And according to a conversation that took place on, and I give you the link here, but a conversation with Dr. Bachner, who is the editor of JAMA, Journal for the American Medical Association, with Dr. Fauci, we may be able to at least know whether we are dealing with a safe and effective vaccine by early winter, late winter, beginning of 2021, Dr. Fauci said. So I think it's important, if you think about normal vaccine development taking years, the amount of effort the entire world is putting forth trying to come up with a vaccine so we can get back to life as it was. Right now, we have a new life, a new way of dealing with things that we're adjusting to, but of course, I think we all would like to go back to a non-mask wearing era. There is a coronavirus vaccine tracker. It's something that's published by the New York Times, but it actually has excellent news. Researchers around the world are developing more than 145 vaccines. That is incredible. I remember working with Hank McKinnell when he was CEO of Pfizer, and he was talking about the amount of money that went into animal vaccinations and how if you went into a production plant where they made animal vaccinations, how remarkably clean and everything was brand new and fascinating. But when you walked into a human vaccine production facility, it wasn't nearly as nice because there was no profit. Well, this time it looks like people are putting profit motives aside. I'm sure there's some there, but we have 145 agents that are being looked at for vaccines. We have 21 that are in human trials. I mean, these are pretty remarkable numbers for a pandemic. Well, we just found out what was causing it December of 2019. So the scientists are racing to produce two main components here. It has to be safe. That is number one, or Americans won't go for it. It has to be effective. People don't want to get stuck and it not work. So the whole goal is they're looking to come up with something in remarkable speed, using people around the world looking for a safe and effective vaccine by next year. Just as a bit of a review, I've been involved in research basically since I started at the Grady Health System 28 years ago. I thought I would go over some of the basics in research so you can have an idea of where we are. So preclinical testing, that's where scientists give the vaccine to animals such as mice or monkeys to see if it produces an immune response. So we have a wonderful HIV vaccine core here at Emory, and they have a wonderful way of managing the animals so there's no animal cruelty. Phase 1 safety trials. Scientists give the vaccine to a small number of healthy people to test safety and dosage, as well to confirm that it stimulates the immune system. So phase 1 trials go into humans. Phase 2 expanded trials, scientists give the vaccine to hundreds of people split into different groups, such as children or the elderly or men and women, to see if the vaccine acts differently based on race, based on age, based on demographics, based on ethnicity. The trials further test the vaccine safety and ability to produce an immune response. Phase 3 are the trials when they really are broad-spread trials in humans. Thousands of people, and we want to see we don't want to see how many people don't get infected. We want to see how many people become infected. If you've had the vaccine and it's effective, we shouldn't see a lot of people converting, compared with volunteers who receive a placebo. So this is actually a trial where a large number of people get the vaccine and another large number of people don't get the vaccine, and we see how many cases in one arm versus how many cases in the other. Is it producing a response? Then we go through the approval process, which in the past could have been remarkably painstaking, but based on the nature of this pandemic and the speed in which the regulatory agencies around the world are working, each country will review the trial results and decide whether to approve its vaccine or not. So if something is approved in China, for instance, it might not be approved in the United States until we are comfortable with our data. Just giving you an example, it could be the other. We produce something in the United States, we find it's effective, they might not want to use it in China. During a pandemic, a vaccine can get emergency use authorization. Remember, we talked about that several times before getting formal approval. Then there is the United States WarpSpeed Program. I did speak to this a few weeks ago, where the government is actually speeding and doing things simultaneously. So there are 5 or 6 entities that have received funding, and not only are they received funding for the testing and development of the vaccine, but they're already producing once they find it has some efficacy. So they'll have hundreds of millions of doses ready to go when it is approved, as opposed to you get it approved and then you start with the manufacturing. So this is a very important effort we're taking, and people are going to be expending a lot of money, which is why your taxpayer dollars are going to this, because we have 5 or 6 entities simultaneously doing this, looking at different modes as well. A couple vector vaccines, a couple mRNA vaccines. And then one of the other ways that we can speed trials is looking at combined phases. So you accelerate the development and say, so some of the coronavirus vaccines are in phase 1 and 2. And that way they're tested for the first time on hundreds of people, because we're trying to get this as fast but as effective as possible. So if you literally look at the number of trials that are going on, we have over 125 in preclinical studies, so they're not in human trials yet. We have 15 trials that are in phase 1, so they're testing safety and dosage in healthy individuals. We have 10 trials that are in phase 2, so their vaccines are expanded for safety in trials and whether or not we get a response. And we have 4 trials that are actively or getting ready to start phase 3 trials, so large efficacy trials. So we truly are making remarkable progress on vaccine development, and something I know we all are looking forward to. What about testing? Testing volume for COVID-19 has honestly overwhelmed some of the commercial and national reference labs. If you're in Arizona and then I'm not telling you something that you're not aware of. If you're in parts of Florida or even parts of Texas, you might be not hearing something that's new, but it's taking a longer time to get turned around on these tests. Sometimes it's several days, sometimes it can be a week or longer. What we really should look at is a way to test more broadly, even in people without symptoms. The critical window period for transmitting the virus starts a day before symptom onset. So if people could know their status, they would be less likely to infect others because they would stay home. And that's one of the keys. Remember one of those key principles about getting our offices back. If you are sick, stay home. Call your doctor. Very important. PCR testing, which is what we normally do, those are those nasal swabs that if you've had that experience, which is the gold standard, but it has a lot of problems right now, and it's expensive, it's slow, and it basically is straining the lab chain supply. This one individual's hospital, Dr. Brushner's hospital, had to diversify the PCR test to at least 5 different platforms to avoid running low on any one particular test. A nasopharyngeal swab also requires trained personnel to obtain the sample, and you want them trained. Take my word for it. So we've had a few updates. Antigen Test wins FDA emergency use authorization, a new COVID-19 antigen test that can be administered at the point of care. So this would be a test you could actually, it's CLIA waived, and you can do this test in a dental office, and there are all sorts of legitimate things we'll need to talk about further on about CLIA waivers. You can get results in 15 minutes. And so is it going to be as accurate as other tests? Maybe not, but we're going to talk about that in a moment. These antigen tests are relatively a new type of test for COVID-19, and what they do is they look for proteins that can be found on or inside the virus. What about home testing? I remember going in front of the Food and Drug Administration twice, their Blood Products Advisory Committee, testifying on the importance of having home HIV testing. Now, that was a little bit different because of the stigma associated with HIV. Now we know that several companies are actually working on home COVID-19 tests. I'd be more than happy to go back up to the FDA and talk to them about this, because it's a remarkable way of letting people know their status without leaving their home, but they're none approved. So let's just talk about the concept. One thing that may be holding up the FDA approval on these products is that they're less sensitive than PCR. PCR is the gold standard. The test that we do with a nasopharyngeal swab, and it goes to the PCR, is going to be able to detect virus, and it's going to be virtually 100% sensitive and specific. Whereas an at-home test, and we're looking at saliva, which is something I've always been a big fan of, it's going to miss some cases, but it's also going to identify a lot of cases. And then there's some concern it might give a possible false negative result. What are the benefits of home testing? First thing is it's cheap. The estimated cost could be between $1 and $5. That might be a protection cost, and I don't do sales on that level, but others will let you know. But the cost, I don't think, will be absurd. It can be done on saliva. I love this wording. No brain biopsy is performed. I honestly felt like I had a pituitary biopsy when I had my last COVID-19 PCR test. They can be done frequently. It's a saliva test. It could be done in college students or healthcare workers or bus drivers or anybody who is constantly possibly dealing with the public and possibly could be exposed. And it'll answer key questions. The key question, am I contagious now? So that's something that Paul Sachs, who is an infectious disease physician, wrote about in the New England Journal of Medicine under Journal Watch. And it was really an interesting read, and I highly suggest it. So we talked about some of the advances that we've seen in testing. We've talked about some of the vaccine stages that we're at. But our real point of holding these webinars, besides giving you the medical clinical update, is where are we with our infection control? We talked about where we are with our PPE. We talked about where our practices are, but we still have infection control concerns. And there are some significant ones. I do believe that dental offices can't completely eliminate COVID transmission. I don't know any environment unless 100% of people are vaccinated with 100% effective vaccination where we're going to be in an environment where somebody doesn't get something. So Dr. Poland, who is an infectious disease specialist at the Mayo Clinic, and he's also a spokesman for the IDSA, says he thinks some infections in dental settings are likely to happen or to be inevitable. But the hope is that the recommendations for practices that all dentists are following or should be following will mitigate that risk. It's also important in the same breath to say that as of now, there has not been a documented case of a healthcare worker or a patient becoming COVID positive after a visit to the dental office. Let me repeat that. There's no documented evidence that any dental office has given COVID to a patient or a staff member. No matter what you might read on social media, I'm looking directly into the camera just to get this point across to you. But there is the possibilities, and we have to take every step possible. So the very good news is that the WHO and the U.S. Center for Disease Control say there have been no confirmed cases, as I've just mentioned, in the dental office. It includes follow-up by the CDC on news reports that suggest such infections, says Michelle Newberger, a dental officer for the CDC's Division of Oral Health and a member of CDC's COVID-19 Response Infection Prevention Control Team. And I have worked closely with the CDC almost my entire career and still have complete faith in their oral health branch as well as their ID branch. The reality: dental settings, we have unique characteristics that warrant specific infection control considerations. Think about extraoral aerosol evacuation. Think about the HEPA filtration that we're putting in. Think about all of the different steps that we've been taking. The spray produced during certain dental procedures could also include small aerosolized droplets of COVID-19 if a patient has the virus. And these droplets or aerosols can remain in the air for 3 hours, as we've talked about before, and can potentially spread the virus to dental staff or the next patient. That's why the ADA has that recommendation. If you have performed an aerosol generating procedure, you should leave the room after the procedure and let the room sit for 15 minutes. Let that aerosol drop. There are also some reports that you can use those HEPA filters in the room to help clean it out. We have them in our rooms and are actually in the process of trying to purchase some more extraoral aerosol evacuators. I'm going to once again stress a remarkable document that did put in all of the recommendations, including checklist and practice tips together. It's the OSAP and DentaQuest Partnership for Oral Health Advancement, Best Practices for Infection Control in Dental Clinics during the COVID-19 pandemic. As we are aware, this pandemic isn't going away anytime in the near future, so if you need to get a copy, please do. It's a living document, and changes will be made as we go through this pandemic. So when you prepare the dental clinic for patients, just taking out some of the information that we've heard before. First thing you want to do is conduct team meetings. Remember the importance of communication. You have to train your employees and make sure that they're updated on the new policies and new rules. And I run a program myself. I have specifically said that certain things need to happen. And when I walk on the floor, I catch people not doing specific things. So I think it's really important to daily go over some of the things that you notice. It's not for retribution. It's not to put anybody down. It's to enforce the positive. So you ask the questions. What are we using for pre-rinse? How are we using the pre-rinse? Are we using the saliva ejector? Or are we having the patient spit? No spitting. So we're using the saliva ejector. Do we repeat it? The answer is yes. I mean, there's certain things that we just need to go over because people get distracted. And so we want to make sure that everybody has the same level of knowledge, whether you are the dental owner of a practice, whether you're front desk, the dental assistant, the dental hygienist. We're all at risk for this epidemic, this pandemic, and we want to make sure that we're all trained and doing the proper things. We have put up sneeze guards in front of our front desk now, going against our open front desk policy because we want to protect our front desk staff. To me, they have the hardest job in public health because they're the keepers to the door. They're the ones that make the appointments. You need to look and see if there's community transmission of COVID-19 in your area. Right now, 70% of the country is a hotspot, so most likely you're in a hotspot area. If there's a surge of COVID-19, consider your decision to engage in practice, maybe aerosol generating procedures that you're doing now. Maybe it's time not to because it's still not recommended. Atraumatic restorative procedures, SDF, glass ionomer, there's all sorts of different things that can be done. If you're in an area of very low incidence and you're doing aerosol generating procedures, make sure you have your N95. If you bring on new staff personnel, remember OSHA still mandates that new staff are fit tested for N95s. The annual fit testing monitoring, I do believe, has still been waived. But new employees, new hires must be fit tested for N95s. The new residents that started in our programs were fit tested yesterday, so I'm really thrilled about that. Strategies for social distancing amongst patients, so that would be waiting rooms, things that you can do with the car, and staff. Where has my biggest difficulty been? Not with the patients, it's been with the staff. How do I keep people from sticking together because they're friends, they work together, they're used to that? How do I help keep a physical distance amongst staff? And if somebody has great suggestions, I'm looking forward to seeing the chat box on that one. Assignments for specific duties related to safe practices that we put in place basically from day one. Methods to minimize aerosol production. Using a rubber dam if you have to take out a handpiece is a great way. Having high-speed evacuation available for dental hygiene, necessary. But right now we're not using the high-speed ultrasonic scaler, but they still have access to high-volume evacuation. Make sure you have a written respiratory protection program in place. That is very important and would be a liability most likely if you didn't. And especially if you're using respirators. If we're just using masks, no, but we're having to use N95 respirators. So if you need help, there is guidance for this, I believe, on OSAP's form. And then make sure you have questions and answers with your staff on a regular basis in case there are any concerns that come up or things they've heard on the news or possible things that they can see in social media. Now, when it really comes to one of the most areas I have to correct on a regular basis, it is donning and doffing the PPE. This is not all that difficult to process, but it is different from what we're used to doing. And so I thought it would be appropriate not for me to try to demonstrate that because, well, you all would laugh. So I'm borrowing some short videos, very short videos from the CDC that really goes through the entire donning and doffing process. It is very important, especially to pay attention to the doffing component, because if you do remember Ebola, this is not Ebola, people were getting infected by not taking off not doffing their protective equipment appropriately. So let's not get ourselves ever into a bad habit. Let's start off with the good habits. So right now, we're going to go ahead and take a look at those videos, and I'll be back shortly.
How to safely put on personal protective equipment, or more commonly called PPE. We will demonstrate one way to appropriately put on or don PPE. More than one donning method may be acceptable to your facility. It's important that you receive training, demonstrate competency, and practice your healthcare facility's donning procedure. First, identify and gather the proper PPE to don, including an appropriately fitted isolation gown, a NIOSH-approved N95 filtering facepiece respirator or higher level respiratory protection, or if a respirator is not available, a face mask, a face shield or goggles, and a pair of disposable patient examination gloves. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Put on the isolation gown. Tie all ties or snap all snaps. You may need assistance from another healthcare provider. Put on the N95 respirator. When using a respirator with a nose piece, fit it to your nose using both hands. Do not bend or tent the respirator. Extend the respirator under your chin, protecting both your mouth and nose. Pull the top strap over your head, placing it on the crown. Then pull the bottom strap over your head, placing it at the base of your neck. Lastly, perform a user seal check. Do this by using your hands to cover the surface of the respirator and gently exhale, checking that the facepiece bulges slightly. Then, while keeping your hands over the respirator, take in a quick, deep breath, checking that the facepiece collapses slightly. If air escapes through the edges, readjust the fit of your respirator and perform another user seal check. Do this each time you put the respirator on. If a respirator is not available, put on a face mask. Extend the face mask under your chin, protecting both your mouth and nose. If the mask has loops, hook them around your ears. If it has ties, secure them at the base of your neck and crown of your head. Next, put on a face shield or goggles. Once again, perform hand hygiene. Lastly, put on your gloves. Pull the gloves down so that they cover the wrist of the gown. You are now ready to enter the patient's room. How to safely take off personal protective equipment, more commonly called PPE. We will demonstrate one way to appropriately take off or doff PPE. More than one doffing method may be acceptable to your facility. It's important that you receive training, demonstrate competency in removing your PPE without contaminating yourself, and practice your healthcare facility's doffing procedure. Remove and discard your gloves. Gloves can be removed using more than one technique. For the glove-in-glove technique, pinch the outside of the glove near the wrist. Peel downwards, pulling the glove inside out. With your ungloved hand, slide your finger under the wrist of your remaining glove. Again, peel downwards, turning the glove inside out. Discard the gloves. For the beaking method, pinch the outside of the glove near the wrist. Using your finger, pull the glove inside out and over the fingers and thumb to form a beak. With the beaked hand, pinch the opposite glove at the wrist and pull downwards, turning the glove inside out. With the ungloved hand, pull the beaked glove off, touching only the inside of the glove. Next, remove your gown. Untie all ties or unsnap all snaps. Some gown ties can be broken rather than untied. In that instance, break the ties gently, avoiding a forceful movement. Reach up to the shoulders and carefully pull or roll the gown down and away from the body. Dispose of the used gown. You may now exit the patient's room. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Be sure to clean your wrists where the edge of the glove was located. Carefully remove the face shield or goggles by grabbing the strap and pulling upwards and away from your head. Do not touch the front of the face shield or goggles. Next, remove and discard the respirator or face mask. If you are wearing a respirator, remove the bottom strap by grabbing only the strap and bringing it carefully over your head. Grasp the top strap and bring it carefully over your head, and then pull the respirator away from your face without touching the front of the respirator. If you are wearing a face mask, carefully untie the straps or unhook them from your ears and pull the mask away from your face without touching the front of the mask. Lastly, once again perform hand hygiene after removing the respirator or face mask. You have now completed the doffing procedure.
I'm going to talk a little bit about the tale of an anxious patient. When the gentleman finally got up the courage for his delayed checkup, the dental office had lots of procedures in place that made him feel better. A member of the staff called with a list of questions about his health a few days before the appointment, then again on the day after his checkup. This gentleman was told to call the receptionist from his car when he arrived and then wait to let a staffer open the office front door so he didn't even need to touch a doorknob. Maybe a little overkill. They led me straight to the hand sanitizer, he says. Next was a temperature check. Everybody wore masks until I had to take mine off for them to work on me. And the hygienist and dentist had full face shields for when they were working close in. So communicating with our patients, communicating with our staff is one of the most important things we can do. We have guidelines to help us put our policies and procedures in place, make sure they're in place. Go over it with your staff. Make sure your staff members are aware of all of the things they can do to remain safe. Don't be scared by some of the things that you see on social media. Put out your positive messages. Put out your success. We're at the beginning of a pandemic. Hopefully we'll have a vaccine and treatment soon. But while we're here, it's our job to provide the safe dental visit and provide that remarkable service we have provided our entire careers. You can't be healthy without oral health, and that takes the dental team. Thank you, and back to you, Dr. Severance.
Thank you, Dr. Reznik. And again, we'll see you in a couple of weeks with your clinical update. As always, if you have any questions, concern, or ideas for future topics for this webinar series, please let us know at webinars@henryschein.com. And please subscribe to our YouTube channel by clicking the subscribe button below. As a reminder, we'll see you next time, July 24th at 2 p.m. Eastern Time. And as always, please stay safe and stay informed.